Good evening, sir.
Good evening. Yes.
Sir,
Are you able
can you
to?
hear?
Uh, hello, are you able to hear me?
Yes, sir. Yes, sir. Yes.
Yes. Now, what is the issue? Let us continue. Now, what's the go ahead with the schedule as such.
Okay, sir. So, Kishore sir is joining. No. Okay.
Sir, namaste. Namaste, sir.
Namaste. How are you? ಹೇಗಿದ್ದೀರಿ?
ಚೆನ್ನಾಗಿದ್ದೀರಾ ಸರ್?
ನಿಮ್ಮ ವಾಯ್ಸ್ ಯಾಕೋ
Yeah, sir.
ಕೇಳಿಸ್ತಾ ಇಲ್ಲ ಕಿಶೋರ್.
ಹಾಂ ಸರ್, ಹಾಂ ಸರ್.
ಸರಿ.
ಸೊ
ಎಸ್
ಹಲೋ,
ಹಲೋ.
ವಾಯ್ಸ್ ಕೇಳ್ತಾ ಇಲ್ವಾ ಸರ್?
ಈಗ ಸರಿ ಆಯ್ತು. ಸರಿ.
ಹಲೋ ಸರ್.
ಈಗ ಸರಿ ಆಯ್ತು.
ಸರಿ ಸರ್, ಸರಿ ಸರಿ.
ಓಕೆ.
ಚೆನ್ನಾಗಿದ್ದೀರಾ ಅಂತ ಕೇಳಿದೆ ಸರ್.
Sir, can we
Sorry,
record the
sorry.
video?
ಓಕೆ ಆಲ್ ರೈಟ್.
ಸೊ ಈಸ್
ಆಲ್ ರೈಟ್ ವಿ ಕ್ಯಾನ್.
ಹಾಂ ಸರ್. ಯಾ, ಶೋರ್ ಶೋರ್. ಯಾ, ಪ್ಲೀಸ್ ಗೋ ಹೆಡ್ ಡಾಕ್ಟರ್ ಬಾಸಿಲ್. ಎಸ್, ಪ್ಲೀಸ್ ಸ್ಟಾರ್ಟ್.
Yes, sir.
Sir, could you go through our paper, sir?
Yes, I have gone through that paper.
Okay, okay.
That gives a different sort of view about the diagnosis. But
Yes, sir. Yes, yes.
I consider this that's not a very serious issue. Like when the different Ayurvedic make different diagnosis, that doesn't make much a big issue. Anyway.
Okay, okay.
Right.
Sure.
So, we have 5 diseases from which one you can select, sir. It's according to your
May select
expertise.
any one of that. So that left choice is left to you. Yes.
So,
go
Dr.
ahead.
Basil, yeah,
Haan, sir.
I think maybe GIT you can start with. If sir
Yes, sir.
is has got some time, he may opt for some other disease as well afterwards.
Now,
Once you finish one case.
Okay, sir.
Yeah.
Sir, should I have to read, sir?
Okay, I am reading it now. But what I
Okay,
am
sir.
supposed to do with that now?
Sir, the structure of this interview is something like this, sir. So we will be presenting a case to you first. The presentation, the history, the clinical examination, and this other investigations, and then you will be asked to describe how you will diagnose it, how you will treat it, and what will be the pathology and physiological basis that you consider to be important as per Ayurveda. So this is how we have planned the interview, sir.
Okay, all right. Make to modern intensity, radius to the back, persists for minutes or make and sometimes relieved by defecation for the last 3 months. Weight loss during this period, and there is no history of any joint pain, heat problem, fever, cough. Right. Right. Are there any history of investigations done in that patient?
Yes, yes, sir. Yes, yes. It will come up next, sir. Basil,
Okay.
Basil, please proceed.
Right. Okay. Right. Next. Right. Weight 45 kg. All right. Right. Okay. Go ahead. Right. Prakriti Pitta Pradhana. Okay, further. corpuscular volume. Okay, fine. Next, go ahead. Any more investigations done? Are there any more investigations done?
Microscopic examination, blood, colonoscopy.
Right. Focal area of inflammation. This contains involvement, pseudopolyps and ulcer noted in descending transverse colon, rectum relatively spared with major erythema. Okay, terminality.
Sir, this much, sir.
Okay, all
This much,
right.
yeah.
Focal right, fine. Next, is there any more thing done? Study?
No, sir, only. This is the last, sir.
Yes.
Right. So, obviously, the patient is of ulcerative colitis like condition. From Ayurvedic point of view, I would consider this as Grahani. There are two, particularly Tridoshana Grahani or maybe Vata-Pitta Grahani. So, and my treatment protocol in that case would be, I would be preferring the drugs which would take care of that Jirna. So Deepana Pachana Aushadhis and one of the drugs and Stambhana Aushadhis. And what I would prefer is Anandaveri and Mustakarishta as the drug. That's what I would prefer in such patients. And patients also may be given Pichabasti. Pichabasti, that would help the patient. That's the in brief what we do. Now, what sort of detail you want to know?
Okay. So, sir, so these drugs you will give for how many? I mean, how long?
The duration of the treatment is based upon the investigational findings. Now, investigational findings are suggestive of ulcerative colitis, and of course, I would go for further investigation of ANA, antinuclear antibody, to rule out autoimmune pathology. If there is a autoimmune pathology, naturally the treatment duration would be very prolonged, like it may be years, maybe months or years together.
Okay, sir.
But if it is the other way, like it's only infective pathology, it could be around 1 or 2 months. A simple infective colitis, it could be 1 or 2 months. That would be enough.
Okay. So you, as we all know, sir, your treatment prescriptions are very brief, and you don't give lengthy prescriptions. Only 1 or 2 drugs and maybe 1 intervention.
Okay.
So our question is, your decision to choose these drugs is based on whether it is based on the presentation, or whether it is based on your diagnosis, or whether it is based on the pathophysiology of Ayurveda. I mean, where does Ayurveda come here?
Yeah, definitely yes. My selection of the drug would be based upon the dosha assessment and all that Ayurvedic parameters of study. Now, Ayurvedic parameters of the study would suggest about the Agni-Mandya, and at the same time there is a Dhatu Sramsana, that a liquid flowing. So, there is a need of a Stambhana and Deepana Aushadhi. Now, it could be anything else, like it's not necessary that Anandaveri would be the only drug. Anandaveri is one drug which I would be using quite frequently in my clinical practice, because I select a few drugs. My practice would have only around 30 to 32 drugs in my clinic.
Yes.
It can be any other drug of that category which would have a Deepana property, Deepana Pachana property, as well as a Stambhana property. Now, whether it requires more drugs or more of the medicines or lesser of medicines, that depends upon individual prescriptions. And from Ayurvedic point of view, there is nothing wrong if somebody prescribes to some other drug, but if it is on the lines of Deepana Pachana, taking care of the Agni-Mandya and maybe the condition of the ama in the stools, I think that would be a perfect treatment. Drug selection, it can vary from person to person, and that doesn't make much difference.
Perfect, sir. Perfect. So what we are interested in knowing is that your identification of dosha, is it based on symptoms the patient presents with?
Yeah, primarily the symptoms.
Primarily the symptoms.
Primarily, it is the symptoms which make the diagnosis. But of course, in the case which is presented, it's quite obvious with the symptoms. You can make out that either it's a Kapha Pitta Vyadhi, or it could be tridosha, the maximum. So there could be some variations, and the dosha condition would vary in the patient day by day. It's not that the dosha assessment which I have done now may not be the same in the next visit. Next visit with our drugs, there could be some modifications, and then the prescription may change. Like suppose in that patient, my prescription starts with Anand Bhairavi and Mustakarista. Maybe in the next visit, it could be possible that the patient might have some relief with the bowel movements, but the patient may still continue to have that pain. So there, at that stage, there could be aggravation of the vata, and I would prefer a vata shamaka drug either added to it or maybe changed. Like in that condition, I may prescribe Agnitundi and Agnitundivati and Mustakarista, or so on. So the assessment has to be a continuous assessment from this point of view. It's not that you brand the disease like it's Vatakapaja or Vatakapaja or so on at one stage, and the same has to be continued. So from my point of view, our assessment should be real-time based assessment, and the prescription also may change or may be continued same. That depends upon how the patient responds to the treatment. So if our assessment in the initial day is correct, maybe throughout the course of the disease, we may continue the same treatment or we may modify. That depends upon the real situation. Unlike the contemporary medicine, where you may have a fixed regime for a disease, so from our Ayurvedic point of view, it's not a treatment for the disease, it's a treatment for the patient. And the patient's condition may change, and correspondingly, we may have to modify our approach to the disease. This is what I do. Right?
So do you consider samprapti anywhere, and do you aim at samprapti vigatana in your practice?
Yes, definitely yes. Now samprapti in this patient would be same like the exact ahara vihara. There has to be more detailed history about the exact food the patient consumes and the daily activities. So those they need to be modified. Like in the presentation, the details given about the food habits is not very detailed. Like it's just casual. Maybe most of the times it could be due to the junk food which is consumed, which could be the initial factor. And that etiological factors have to be considered wherever it is possible. At times, I do agree, at times the etiological factors cannot be made out. But in majority of the situations, we can make out those etiological factors to a great extent, and they have to be avoided. That's the first step from the point of view of samprapti vigatana, that etiological factors have to be avoided. The next part is whether the patient may require a shodhana chikitsa or whether the patient can be managed with the shamana chikitsa. Usually, patients prefer the shamana chikitsa. Shodhana chikitsa, of course, it looks more laborious now. Though from the theory point of view, shodhana chikitsa is better. I do agree. But from the practice clinical point of view, for the sake of convenience of the patient and to keep up the rather practical aspects of the patient, we always prefer shamana chikitsa. So when I say Gandhakara Anand Bhairavi Mustakarista, that's the shamana chikitsa. But suppose the patient doesn't respond to that, then I will be preferring the shodhana chikitsa like a Pichhabasti. Basti also is a shodhana. That would be one of the options which is possible in that patient. Or suppose the patient may have a different change in suppose if it is simply a mild colitis. Now because that part, whether it is really ulcerative colitis or something else, that's not yet confirmed. So suppose if it is a simple mild colitis and the patient has these symptoms, the patient may have developed a constipation later. So in such condition, patient may have to be given a mrudu virechana also. So that samprapti again is a dynamic process. It's not a simple single step process. So many times students conceive samprapti as a single step process, which is not really true. Samprapti also is a dynamic process which may get modified within that structural limit, base structural limits, and we may have to modify our approach to the treatment at that situation.
Okay. So do you consider the factors like maybe Rutu, Prakriti, and Kostha, all this during your
Definitely yes,
treatment?
definitely yes. These would have always the value. See, Kosta Pariksha is very difficult from the routine clinical point of view. In a setup like a general practice, Kosta Pariksha is almost impractical because you will have to give some food and then, but with some guests, you may have certain modification of the guests about the Kosta. Rutu and Prakriti, they definitely have a role to play. Suppose that patient now, as per the assessment which is presented, that Prakriti is claimed to be Vatapittaja, maybe suppose the patient has a predominant Kapha Prakriti in that condition, then in that situation I may add Chitrakajivati, some more Tikshna Kapagna Aushadhis also may be added. If it is simply a Vata Prakriti condition, maybe in due course of time, as the patient has responded, we may give some Snigdha Dravyas, and I would always prefer Draksha, change from Musaka to Draksha in such condition. Later on, not when the patient has the constipation. Once the patient has improved, the Agni has become somewhat normal, then we may give some Balya Rasayana Aushadhi if the patient is obviously Vata Prakriti or the aggravation of Vata. So, Prakriti assessment definitely has a role to play. Dosha assessment is the main key for the treatment. Then Rutu, seasonal, in the majority of these conditions, it may not have much same significance like a GIT problem. There may not be much significant problem. In respiratory conditions, it's very obvious the seasonal effects. So it depends. It may not be to the same extent as mentioned in the original Samhitas, but whereas there is a practical relationship that can be made out. Right.
Okay. So, sir, the drugs that you have chosen, the interventions that you have chosen, so at what point of samprapti do they act? I mean, do you consider this while planning the treatment?
I think that's the basic issue which I have already made out. Samprapti is a dynamic process.
Right.
It's not a single. So, to point out at which level it affects is not a correct one. At that moment, when you have assessed the patient, we tackle that samprapti with a specific medical approach.
Okay.
If your assessment is perfect and your yoga also, that prescription also is perfect, and every other factors are supportive, the patient may have a complete resolution with that. So first step. Suppose the response is not sufficient, or rather there is no response at all, then there could be a reassessment of the samprapti and then you may modify. So from Ayurvedic prescription point of view, there is a good scope for this kind of a modification of assessment also, because after all, samprapti cannot be made out objectively as per the current investigations. With the current investigation tools, with the biochemistry and other laboratory tools, you may have a very objective assessment of the pathological condition. From Ayurvedic point of view, a objective assessment of the Prakriti samprapti may not be possible, because simply the reason is samprapti is a dynamic process. It can change. It can change according to the status of the dosha in the body. It can change into the status, change according to all the other variable factors like ritus and the diet, food, everything, ahara, vihara, etc. So naturally, we may have to make out the samprapti at that moment as we assess the patient. Then we start with the treatment. If the same continues, of course it's well and good. If not, we may have to just modify according to the assessment as we see. I think that's exactly the point which I have already clarified. So my prescription would never be the same throughout. Every follow-up, there will be a review of the prescription, and if necessary, we may modify. If not, the same may be continued.
Right. Suppose, sir, in Ayurvedic text they describe like this vata located in its particular place, then it moves to some other thing, and then drags other dosha and all this. So this stepwise explanation of this samprapti, is it something that is clinically you consider?
Yes, definitely. Yes. See, we may see it's not simply the movement of the dosha. Samprapti is not simply the movement of the doshas. It's about one dosha affecting the other. How that total cascade of events continue to occur. how they are linked like. So it starts with the etiological factors, like it could be the food, diet. See, of course, it's often difficult to make out because most of the patients would not easily identify the food factor or maybe the relevant factor. So by clinical experience, because we see large number of patients, at times we can pick up those issues somewhat easily, at times we may not. But it starts with that, the etiological factors. Then how the things have accumulated for. There could be some other precipitating factor also. So in this patient, now in the history given, like there are certain precipitating factors like some I think specific food, like it will aggravate the symptoms. That's exactly presented in the history. So from that point of view we start, and then the symptoms also, like the patient also has some burning sensation, and that's exactly how it starts with the amashaya, the reduced appetite, burning sensation, bloating sensation. That's how the pathology starts with the amashaya. Then if you go into the evolution of the disease, you may have that symptoms, like the patient may have the last part, like the frequent stools which are not digested, semi-digested stools and related issue. Then the next part of that would be that kind of ajirna has resulted in the dhatukshaya. So her blood hemoglobin level is somewhat on the lower side. So, then samprapti vikhatana in that case would be, we start with Agnimandya. Agnimandya has to be corrected. Then that the passage of the stools, that has to be corrected with the Stambhana Aushadhi. Once the patient has corrected these, then if necessary we may give a rasayana, maybe Brahmana Aushadhis like Draksharishta in the later part to correct that part of the anemia. So this is comprehensive in as such. But again, this would be depending upon how the patient responds to the treatment. It's not
Right.
that we can write the prescription now for the whole course of the disease completely. It has to be
I
a
get it.
medical assessment. So Ayurvedic
Yes.
prescription or Ayurvedic practice has to be based upon repeated assessment of the patient, that repeated examination of the patient and modification. So artificial intelligence, computerized technologies, or something like what we say as a standard protocol of the treatment, specific guidelines, they need
That
to be,
doesn't work.
They need to be looked at in a different view. Of course, guidelines are there. Guidelines are for the sake of being flexible, being corresponding to the current exact situation at that point, than simply giving a strict guideline which has to be followed. So
Right.
the approach may have to be different.
Right. So, do you consider the pathophysiology in modern science while prescribing these medicines?
Yes. So it's not
Yes.
about prescribing medicine. The
Ah.
pathophysiology of the current science would be necessary to maybe predict the prognosis of the patient. See, in my clinical practice, I would always consider that current contemporary diagnosis as one of the important tool. Without making a contemporary diagnosis, I may not treat any patient. But that diagnosis doesn't really change the prescription. The prescription would be based upon dosha assessment. But the assessment from the other part of the contemporary assessment is absolutely necessary to predict about the possible complications, to predict the prognosis, and another important point in the practice is, see, we may have an allegiance to the system. I am committed to Ayurvedic system, but my patient should not suffer because of my allegiance, my bias. So patient should be given the possible best, possible better option. Whenever there is some situation where I cannot manage, so it's a asadhya vyadhi. Suppose if there is a asadhya vyadhi from my point of view, then whether that asadhya vyadhi can be treated with the contemporary system or not, this also has to be known, and the patient has to be guided properly, like which would be the better. See, of course, there are two aspects. One, the patient may select or opt for either Ayurvedic treatment or contemporary treatment or maybe mixopathy based upon patient's preferences, but that is a learned preference. That's not an educated preference. From a clinician's point of view, we should be in a position to give that educated preferences, and I would do that. I will always do that. So whenever there is some situation where we may not be able to manage with Ayurvedic medicine at all, or if there is a need for some other contemporary medicines also. The choice would be either the patient may have to go to some other hospital or some other this practitioner who would prescribe modern drug, or maybe at times I may prescribe some modern drugs also in my hospital, but not in my clinic. In my clinic, I don't prescribe any modern drugs. It is
Right.
purely Ayurvedic drugs which I prescribe. So, but it's quite important to educate the patient about the real situation and ensure that the patient is safe. That's
Right,
my priority.
right.
That's my priority.
Sure. Yeah, sure. So Kriyakala, do you consider in this case, for example?
Yes, Kriya Kala definitely is better. What happens is in the clinical practice, the initial Kriya Kalas like the Vruddhi,
Sanchaya, Prakopa.
Prakopa, even Prasara, Sthana Sanchaya becomes irrelevant because no
Okay,
patient will
okay.
come to you before that stage.
Okay,
So
right.
from the
Manifestation of symptoms, right? Sthana
that we
Samshaya.
have is Vyakta Bheda. Most of the times the patient comes at the Bhelavastha.
Vyakta,
Bhelavastha is
huh.
one situation.
Hmm.
But these Kriya Kalas would definitely have a relevance. Suppose if you are guiding a patient, guiding a healthy person, in a situation where you are advising the healthy person, this would be quite useful. Or at least for ourselves, for practitioners, Vruddhi Sanchaya definitely are useful. If you are able to identify those dosha lakshanas, definitely yes, we can prevent and remain healthy. So I would always say, like for Ayurvedic students and Ayurvedic doctors, the Vruddhi Sanchaya Prakopa is very irrelevant. For a patient otherwise, unfortunately, we are not in a position where the patients can identify these symptoms easily and go for the preventive step. Maybe from the other point of view, in due course of time, what we should do from the policy makers' point of view and so on, or point of view of education, social education, or popularizing Ayurveda and so on, that aspect, not the clinical practice. This would have a very significant relevance where we can make the common man identify these earlier Kriya Kalas. And
Okay,
the
okay.
patients can have such steps by which it may not go to the next Kriya Kala. It's something which would be maybe the utopia, dream, which practically is not possible, but at least some of the patients we may guide about that. So from the clinical point of view, in the practice point of view, we see only the patients of Vekta and Bheda. Most of the times it's the Bheda Avastha, and there would be some complications. Then only the patients come to the clinic, majority of the patients.
Okay. So yeah, Dr. Basil, do you have some more questions?
Sir, how does Pichavasti works? What is the mode of action of Pichavasti here?
Pichavasti mode of action is it's the Shodhana, Pitta Shamaka. That's the basic idea of the Pichavasti. It's a Pitta Shamaka as well as a Shodhana.
So do you consider Dhatu Sarata, sir? Dhatu Sarata in your practice?
Sara Pariksha is, of course, not the same extent as it is mentioned in the text. Dhatu Sara and its examination may not be from the point of view of your prescription and management. But Dhatu Sara definitely, yes, it gives the maybe reaction of the patient, or rather, it may help in prognosis. Some of the patients who have a better Sara, they may have a better resistance to the disease process, and that the results will be much better. A patient who has that the Sara of the lower category, even a relatively simpler condition may produce more complications. So from that point of view, we may have to be a bit more careful with the patients with the Alpasaras, whereas the Saras of better category, the response will be much better. But it may not be really modifying the prescription, but as far as the course of the disease and prognosis, definitely yes, it helps.
Okay. So concepts like Ojas, do you consider, sir?
Definitely yes, I would consider Ojas as the vitality, what we say as the science of vitality. That's the primary. That's the primary sign of the Ojas. So all that examination which we do for the vital, what we write as a vital signs, that forms the primary step of the assessment of the Ojas.
Okay.
Further, of course, whether it is perfect or not, the higher levels of the examination Most of the times in the routine clinical practice, these higher level of examinations are not done. We say vitals are normal. That means Vojas is somewhat manageable. If the vitals are affected, there is a obvious Vojo Visramsa or Vojo Kshaya, which requires a certain immediate support. Then later, it also would be Vojas Pariksha, otherwise, the other Lakshanas of the Vojas, other than vital signs, would also help in the management, like whether the patient would follow your treatment protocol or not, whether the patient would respond to the treatment better or not. Even outcome of the treatment is depending upon the Vojas.
Okay. So, sir, when you see a patient, before prescribing something, what goes on in your mind? Like, this dosha has gone into this dhatu, and then srotas, and this symptom, and all this. Do you? I mean,
definitely yes. Before prescribing any drug, I would consider assess the doshas. My mind would be assessing the doshas in that patient, dosha condition, dhatu involved in that patient, and maybe the status of the dosha, and I prescribe the drug which would be relevant to that condition. And of course,
Right.
majority of my prescriptions are rasaushadhis, may not be exactly the same which are mentioned in the samhitas. In the rasaushadhis also, we categorize those based upon the dosha lakshanas. So, selection of the drug would be always based upon the dosha lakshana.
Right. Yes, Dr. Basil, are there any other questions remaining?
And hence, suppose in the same patient, suppose the
sir.
diagnosis becomes ulcerative colitis, even the diagnosis may be Crohn's disease, or it could be simply infective colitis, and there may be a common prescription. I do not change that prescription.
Okay.
So
Okay.
that's one of the important issue. My prescription would not change if the diagnosis is ulcerative colitis, if the diagnosis is Crohn's disease, or maybe it could be infective colitis, something of that sort. My prescription doesn't change basically from that point of view of Anandavira or Musagarisa. The difference comes in only about the predicting the prognosis, the outcome, like the polyps in that patient would be a sign of asargya. So suppose if it is a control, now about the polyps, I am not sure whether the polyps are responsible for the clinical symptoms or not, polyposis or not. Suppose if it is a typical standard polyposis, I may not treat that patient. I may refer the patient for some surgical issues, or maybe confirming like whether the polyps have gone malignant or not. But suppose I have to prescribe the drug, it will be the same.
Okay.
That's because the dosha assessment would be based upon what the patient presents.
So, sir, one more question: whether while you select your intervention, is it based more on your experience, or is it on the text, or is it based on some published evidence?
No, it's mainly based upon the text. So it starts with the whole exercise
Text.
starts with the text. And
Okay.
then after, when you have used the same drug for in a large number of patients, then there would be a instinctual some responses. See, that's the exact point. If I assess the evolution of my prescriptions, like
Yes,
in
sir.
the initial stages of my practice, I used to prescribe more than 100 or 120 drugs in my clinic. Now it has been limited to 30 to 32 drugs. So this is that reduction of the variety of the drugs which I use in my clinic is based upon the experience.
Experience. Okay.
The primary issue is what the text would say, and based upon the contents of the yogas which I prescribe. So my prescription is based upon that yoga and directly given to the patient, which would be what we call as contemporary practice. May not be exactly the Samhitokta practice. Samhitokta practice would be, you will be assessing the dosha and assessing the vyadhi and then prepare a drug for the patient. But in our situation, we have a different situation now. We have the drug ready and we have to make the patient fit into that combination of the drug.
Right.
Our basic ayurvedic approach, theoretical ayurvedic approach would be Rogamado Pariksheta Tadanantara motion. You have to examine the patient and then have a custom made drug based upon the available drugs of any ganas, dravyas and so on. That's exactly what the Samhita would do. And that kind of a skill and that kind of a practice may not be possible in the present situation. But if at all anybody practices, that would be a very ideal Ayurvedic practice, which I may not be able to do because of the other limitations, number of patients we see and so on, and conveniences so on. So we have a sort of modified sort of practice where we have a medicine ready and you have to fit into the patient's condition. So it's just reversible options based upon what we see in the text. In that situation again, it will be based upon the same issues, the textual description first, then of course the clinical experience would be modified or somewhat fine tuning that. The number of medicines, variety of the medicines which may prescribe may be lesser. Then of course, as far as the publications, another issue.
Yes, yes. Published evidence, yes.
I take most of the publications with a pinch of salt.
Right. Right. Okay. So, any reason, sir? Any reason?
I think I should not divulge on that.
Okay. So, okay. So, Dr. Basil.
No. So while prescribing the medicines, do you consider the chemical contents of the drugs or the Rasavikalpa or both? How do you consider?
I'm not getting now. I'm not getting the question. Repeat the question.
So while prescribing the drugs, do you consider the chemical content in your mind that comes?
Not at all.
Not okay.
At all. Absolutely
Okay.
not at all. That assessment of the chemical contents, identification of some radicals or maybe some alkaloids in a substance, that's only for something like from my point of view, it's not an issue at all. I may discuss about those issues academically, but practically I don't bother about that. Any more questions?
Yes, Dr. Basil. I think we have covered most of the questions, right? Dr. Basil.
Right.
So, sir, it is always a pleasure to talk to you and discuss your experiences. And would it be possible for you to give some more, time slots so that we can get a few more cases evaluated? For our, maybe not.
Another 10 minutes, maybe. Now, it all depends. Your schedule is yours, program is yours.
Yeah, I mean, may not be today. Maybe on some other occasion. Maybe next week or.
All right.
Okay. So, sir, Basil will prepare a transcript out of this interview.
Okay, fine.
And he will send it to you. If it is possible, can you go through and revert if there is any any correction or any addition you want to make or some modification. So he will send you maybe by next week. He will mail you, and then we will get back once again to schedule another interview, sir. Because we want we don't want to miss the people like you in our study. So. Will you give your consent for us to name you in your thesis, sir?
Okay, absolutely. No issues. For academic activities, any sort of academic activities, I am open. There is no restriction.
Okay, sir. Because as I told you, sir, the study that we published that received a lot of criticism, saying that you have identified only BMS graduates with 5 years of clinical experience. They may not be having good knowledge of theory. So we are trying to get more, mature physicians who are more well versed in theory, and we want to see whether the understanding of pathophysiology is similar in Ayurveda or not. This is again the same question we are going to address, and again it may turn out to be, as you told, it may be different. Different people may understand differently. So how to understand this complexity, sir?
I think it's not a complexity. It's a rather advantage of Ayurveda. So it's not a complex issue. It's not an issue where we feel ashamed or something like inferior. That kind of a option for individual assessment and that kind of a flexibility in making the diagnosis and treatment is the advantage of Ayurveda. And see, maybe I should not criticize about the contemporary because we consider, because the whole question has come up because the contemporary diagnosis and protocol, evidence-based medicine has become a standard.
Right.
I would put the question the other way. Like, suppose you have a patient of tuberculosis. diagnosis of tuberculosis may be made based upon only the evidence of tubercular organism present in the body. But the patients,
Right.
you may have different categories of patients. You
Right.
have a good number of tubercular patients who are absolutely asymptomatic, accidentally formed. Some of the patients would have only that evening rise of temperature, weight loss, etc. Some may have severe hemoptysis and so on. Some may have complications. Now, you consider that as a single disease of tuberculosis, which from Ayurvedic point of view is not correct. From
Right.
Ayurvedic point of view, we assess the patients based upon their presentation. It could be
Presenting symptom.
it could be a Rajakshma and so on. So it's not based upon the situation. Now, I don't say that the first option is wrong, but that first option has a deficiency. Deficiency is like though you have that this ability to target the tubercular organism and produce a result clinically, it doesn't really explain why these two different patients would have a wide vast varying sort of the presentations. One may have only the fever, one may have that hemoptysis, one may have very critical condition, and you may use vague words like immunity and so on, or you may go to very high detailed level of molecular studies, and then at the end now all that molecular studies at the end ends up in a situation where you cannot make out, and the number of this naming of the molecules, it comes to such level where no human body or not even many of the moderate computers also cannot just follow that, like it comes to level of A to Z names and just code words and so on. That becomes a very complicated issue. Now when I say this, I am not criticizing that, it's not negating that. But from Ayurvedic point of view, you have the other advantage, and these advantages have to be properly utilized along with whatever we have that modern knowledge to the extent possible to benefit the patient and make it treatment. So
Right.
that would be a rather approach than really simply by abiding by the text. Of course, text is core asset, core strength which you have to follow. But at the same time, we need to be contemporary. We need to be aware of the contemporary situation and relevant. Otherwise, the Ayurvedic practice would not be very practical. So, from the practical point of view, these variations, individual variations, and that possibility of making different sort of approaches would be definitely a benefit which is really suitable. Like a patient of tuberculosis coming to me with only that weight loss, vague fever, I may consider Dhatagata Jwara. And I may prescribe only the simple drugs like Mrityunjaya Arogya, then the patient would be relieved. The patient may have a definite evidence of tuberculosis. The patient may have a cavity in the lungs and hemoptysis and so on, Rajakshma, which is asadhya. And bring the patient to maybe antitubercular treatment and the other issues. So that kind of an approach is the advantage of Ayurveda, and that's the benefit of Ayurveda. And that kind of assessment has to be used for the benefit of the patient, not the way like we would criticize. So
Okay. Okay. I get it, sir.
That's the point. So
Okay.
different physicians making the different diagnosis, one disease named with the different names. One of the important theme of that article, I am not criticizing the article, but the theme would be, it's not a criticism, that kind of an advantage or that kind of a this varied approach or so-called non-standard approach is not a
Right.
disadvantage, rather it should be presented as an advantage, and
Okay.
it is really an advantage.
Okay. Right.
That's
Right.
my-
Interesting. Yeah. This is a very interesting take. Yeah. Sure, sir. Yeah. So, sir, Dr. Basil, do you have anything to say?
No, sir. I think all the questions are covered. Sir, are the details sufficient in the case report we have provided? Is there any?
No, I'm not getting that. No.
Are the details? Are the
He is
details
asking, sir,
sufficient?
what he is asking is that the details provided in the case, were they sufficient for you to finalize your prescription? Or would it have been better if we had?
Right. It's not that I will be saying absolutely sufficient. Suppose if I would be taking the history, I would be taking more detailed history about the diet of the patient.
Diet,
Habits of
okay.
the diet.
Huh.
Which of the rasas the patient would prefer. I
Huh.
think that part is not really present in the history. So
Okay.
that would be one part. Then
Right.
investigational approach, I would be just definitely yes preparing either a biopsy or
Okay.
maybe ANA study in that patient, which is not done.
Biopsy was there, I think. Biopsy he
I
presented.
think I did not come across that probably.
Biopsy was there, right?
So maybe
Biopsy
I
was
have
there.
I missed it. I might have missed it maybe.
Okay,
It was
okay,
kind of
okay,
thing.
right.
But
Right,
ANA studies to rule out the possibility of ulcerative colitis, definitely
Yeah.
yes, that would be one
Right.
of the things which we have
Right.
to do. So
I mean, would your treatment be different for a
not at all,
person?
not at all.
Person?
But
Acha, okay, okay.
that I think already I have clarified.
Right.
Right.
No, my question was no whether this person belonged to maybe, for example, Kapha Prakriti. Then would your treatment